Welcome, and thank you for listening to this Geistlich BioBrief related to this interesting case. My name is Dr. Israel Puterman, and I'm a periodontist. I'm currently in private practice in Chevy Chase, Maryland, just outside of Washington, D.C., where a large portion of my practice focuses on managing anterior implant aesthetics with the assistance of 3D microscopy. This case involves the placement of 2 implants in a female in her late 20s to restore congenitally missing maxillary lateral incisor positions. Her aesthetic risk profile was classified as high risk as she demonstrated a high gingival scallop with a high smile line and reduced interproximal papillae at the edentulous sites. Clinically, favorable vertical gingival positions were noted, however, with deficient buccal contour. Following the completion of orthodontics, a CBCT was taken to assess the bone volume, where bone width was found to be sufficient to accommodate ideal implant positions. In order to fabricate a natural buccal contour, treatment options included augmentation of the alveolar ridge and/or soft tissue augmentation with autogenous gingival grafting or a gingival substitute. In order to avoid the increased morbidity associated with autogenous grafting, we used a volume-stable porcine collagen matrix Fibro-Gide. The implants were inserted into proper 3-dimensional positions using a static surgical guide, with the right implant achieving sufficient insertion torque to accommodate a screw-retained provisional fixed restoration. The left implant received a healing abutment until it was sufficiently integrated after 2 months of healing. Minimally raised flaps were elevated from the marginal tissue towards the vestibular aspects of the labial gingiva in order to provide space in which to insert the collagen matrices. A single piece of Fibro-Gide was sectioned and trimmed, beveling the external edges, and the pieces were inserted dry into the gingival pockets with just enough space to receive the collagen matrices. This minimal tissue elevation allowed for the matrices to be stabilized by the flaps alone without additional manipulation. The interproximal tissue was then sutured in a similar manner on both sides, mesial and distal to the right provisional restoration and to the left healing abutment. Once 2 months had passed, the left implant was reverse torque tested and a screw-retained fixed provisional was inserted, allowing for further tissue maturation. Definitive restorations were fabricated by Dr. Paul Craneson, and the patient is very satisfied with the results obtained. She has been seen with 1.5 years of follow-up, and the tissue has remained stable and void of inflammation with improved home care. This case demonstrates the use of a volume-stable xenograft collagen matrix placed concurrently with dental implants in order to bulk horizontal soft tissue ridge deficiencies. A primary benefit to this material includes the lack of need to harvest autogenous palatal tissue that comes with increased patient morbidity and with increased surgical time. Additionally, the full 6 mm of matrix thickness is often thicker than necessary and allows for the material to be easily trimmed once an initial learning curve is overcome. The keys to success in this case include several important decisions: recognition and differentiation between bony deficiencies and soft tissue aesthetic deficiencies, minimal flap reflection allowing for the biomaterial to be used without necessitating additional techniques to stabilize it, use of a long-term volume-stable substitute for autogenous connective tissue grafts to develop buccal root contours, recognition of surgical limitation and slowing down the provisionalization process even if it does not coincide with the planned approach, use of provisional restorations to guide and shape the tissue prior to proceeding to final restoration. Thank you so much for listening to this case report, and I hope to see you soon.